Hello everyone, and welcome back to Money Power Health with me, Nason Mani. This week, we're discussing health and justice. That is, the health of people who are either experiencing prison or probation or systems related to this. And this doesn't just include these individuals themselves, but also their friends and family and their wider communities. So it encompasses quite a broad range of people. Critically, who is in this population and what their experiences are both profoundly shaped by the wider forces that shape health. All themes we have explored in other episodes of the podcast. And this is a population that, while experiencing some of the worst health inequalities and gaps, is underlooked when we think about health inequalities in a range of ways. At least in England, that may be changing, as the CMO, or Chief Medical Officer, is due to report on the health of people in prison or on probation later this year. And in order to discuss this wider theme, I'm joined by two excellent individuals who are currently involved in producing one of the outputs associated with this report. I'm joined today by Dr. Nicola Dennis, who is an acting public health consultant in Staffordshire County Council, and also by Dr. Chantal Edge, who is the National Lead for Health and Justice at the UK Health Security Agency. Both are incredibly passionate about this topic, and as you'll see in our conversation, have a great deal to say, both about the wider forces that shape who experiences health and justice in the UK and how, and what practical steps are being taken or could be taken to improve gaps in this area. I hope you enjoyed the conversation. I certainly did.
Chantal, Nicola, welcome to the podcast. It's fantastic to be able to speak to you guys about such an important issue. And before we dig into it in more detail, I just thought it'd be nice to start with you briefly introducing yourselves and how you came to be interested in health and justice. Perhaps, Nicola, you could go first.
Fantastic. Thank you very much. Thank you for having us on the podcast as well. It's lovely to have an opportunity to talk about this. So my name is Nicola Dennis. I'm a public health registrar. I work in the West Midlands. As registrars, we're moving around from topic to topic and placement to placement, trying to gain all the experience we need to be sort of rounded professionals and consultants. But health and justice, it's something that I circle back to time and time again. My general interest and my passion for it came from learning about the systematic inequalities that we see in our daily lives. In the West Midlands, for example, where I work, our female life expectancy, healthy life expectancy, it varies between 55 in somewhere like Sandwell and 65 in Shropshire. That's 10 whole years of life. And the more you learn about the health of people who are in contact with the health and justice system in particular, the more you see that the sharp end of those systematic differences across society and the catastrophic consequences that they can have. And I wanted to help find ways to close those gaps where I could.
Thank you, Nicola. Over to you, Chantal.
Hi, and likewise, thank you for having me on the show. So, yes, my name is Chantal Edge. I am a consultant in public health, and I work in the UK Health Security Agency, or UKHSA, which is a national agency charged with trying to protect the country from health threats, so things like infectious disease and pandemics and environmental issues. And in the organisation, I am the National Lead for Health and Justice. So my team looks at all these health threats, health protection issues for adult prisons in England, for the children and young people secure estate, probation and immigration removal centres. And how I got into the world, actually, it's been a really, really long journey here. And back to when I was a registrar as well, similar to Nicola, I was working with a hospital team looking at hepatitis and knowing that you can get a concentration of certain types of hepatitis amongst prison population groups. They wanted to do some targeted work with the prisons. And it was my job to go out and speak to the prisons. I live in Surrey. There are 5 prisons there, so quite a few to get involved with. And once I got there, I realised hepatitis wasn't the only problem. There were so many inequalities. There's so many issues you could tackle. I had some passionate GPs and healthcare teams I talked to, and they sucked me down the rabbit hole. I became so intertwined. Ended up doing my PhD on prison health issue as well, and specialising in the area, moving in to become a consultant in this world as well. So yeah, it's been a long time for me, and I'm very glad I got sucked down that rabbit hole.
Really fascinating, and especially to hear the parallels in both your journeys around discovering the sharp end of health inequalities in this particular context. I think that's something that I'd love to circle back to. But I guess just to kind of paint a picture a little bit more for those who are maybe less familiar. We might often think of health and justice in the context of prisons themselves and prison inmates, for example. But maybe, Chantal, you could help explain how many people the justice system affects more broadly and in what ways when we're talking about health and justice.
Sure. And yeah, it's a very, very good question. And I can't put numbers on all of it, but I'll try the best where I can. So as you said, the justice system is really quite broad and covers a lot of different settings. So firstly, you've got people who are in contact, for example, with police custody. And this was one I wasn't sure on numbers. I looked it up and the internet has told me that was around 900,000 people in England and Wales last year were in contact with police custody. And then, of course, some of those may end up in touch with the court system, but they may never see the inside of a prison because they either aren't found guilty of any offence, or they may be given a penalty such as a fine or points on a driving licence, but nothing towards the custody end. Then there are those who may have gone to the court system who are found guilty of a crime but aren't given a prison sentence still. They may be given a community sentence which they serve outside a prison. So these may have specific conditions attached, such as engaging with treatment for substance misuse or for mental health. And that will fall sort of under the probation cohort as well. And then, you've got the prisons themselves. And at any one time across England and Wales, normally the numbers are compiled together because the prison service serves both areas. You've got around 88,000 men and just under 4,000 women. However, that is not the total in a year because it's a very fast moving system, a lot of what they call churn, people coming in and out. So actually the number of people who are in their prison throughout a year is about half that again. And most people tend to think that prisons are all really similar, but actually you could break that down and you'd find that the amount of people going through different types of prisons is quite different. They're really variable in their function and their size and their turnover. And then, of course, whilst people are in prison, some might get moved for a while or for a longer term to a forensic secure hospital. So that is another area where you may find people who are in the justice system that need to go for mental health treatment in that hospital. Then we also have a separate estate for children and young people. That's comprised of a variety of settings, such as a secure school and young offender institutes, and that currently houses around 500 children and young people. But then the biggest number of people are those on probation, so either post-release from prison or, like I said, potentially involved with a community-based sentence. And at any one time, that's around 200,000 people.
Wow.
And this number is set to increase if we move towards more people spending time in the community following the recommendations from the sentencing review. And then finally, it's remiss not to also mention the number of staff and the number of families that are affected. There are a lot of people working in these institutions. There are a lot of families that are really affected, especially if someone goes into prison, and isn't at home with their family. So we have to consider those as well. So the impact of the justice system is really quite far-reaching and affects a lot of people.
Wow. Yeah, thank you so much for outlining that. And I'm already getting slight flashbacks from my childhood in Northern Ireland, because there were people on my street that I grew up with who ended up interacting with the prison system. And I think we're already getting into some of the ways in which, A, that has spillover effects to their families and to the wider community, but also, B, there are really strong patterns in terms of inequalities in access to opportunity, income and education that are worth really reflecting on in public health in terms of who ends up in prison and what their experience is and who ends up interacting and being affected by the systems more broadly. And so on that, maybe go back to you, Nicola, and ask about the ways in which this population is patterned on wider inequality and what we can sort of glean from that. I know that this is something that you've kind of looked into as part of your work.
Absolutely. There's a wide range of systematic differences and inequalities when we look at the prison population, particularly in early life experiences, unfortunately. So when we look at the latest data that's available for people in prison, when we look at things like taken into care as a child, so it's estimated that across the general population, 2% of people are taken into care as a child. When we look at the male prison population, that goes up to 24%, and the female population, 31%. So an absolutely massive difference in that big early life experience. When we look at people who've experienced abuse, that's any sort of abuse, verbal, physical, sexual, etc., the general population, the estimates say about 20% of children, male prison population 27%, and 53% in the female prison population, which is absolutely horrifying in terms of not only that inequality between the general population, but also the female prison population. When we look at people who observed violence in the home as a child, again, it's 14% in the general population, 50% in the male population of prisons, and 50% in the female prison population. So we're seeing this real kind of difference across lots of very traumatic early experiences. And we're seeing that burden fall particularly heavily on the female population as well. And then when we look at school outcomes, you also see massive differences there as well. So in the general population, it's hard to tell, but we think that around 5% of people regularly truant from school. But maybe it's something that's changing a lot at the moment post-pandemic, but 5% in my statistics, 59% in the overall prison population, absolutely massive kind of disengagement from school and education. That feeds through to being expelled from school. So again, 1% in the general population-ish, 43% in the male prison population, 32% in the female population. That then leads to leaving school with no qualifications. So around 15% in the general population, 47% in the prison population. And so we see these long-term trends as well. This isn't something that's just happening now. It's something that's been happening for a long time, and it's really sad. It's really important to remember, though, that most people who are taken into care or expelled from school and all of those things, they don't end up in the prison system. And there's nothing inevitable about any of this. But the fact that we're seeing these patterns over years, it suggests that having those traumatic experiences, like experiencing abuse, observing violence, being taken into care, it's indicative of broader kind of inequalities and challenges which make that contact more likely later on. And the trends around school and truanting and expulsion, it points to a group that's got fewer economic opportunities later for making those positive changes and breaking out of that cycle. So some real massive inequalities.
Gosh, Nicola, thank you so much. I mean, that was a really comprehensive overview. And yet at the same time, you know, there's kind of an ocean of meaning behind all of those words, right? In terms of the scale of the difference and the kind of automatic questions it poses about, I guess, what lies upstream of the prison population. And hopefully we can get into this a little bit more, but just to say that one of the core themes of the podcast is the links between money, power, and health, right? And sort of understanding that health is to a large degree shaped by the wider forces in society, and that we in health, we at times can be quite narrowly focused on individuals and their outcomes and not see the kind of water that they're swimming in as much. And what you've described is really just the way in which the water that people who end up interacting with the justice system differs from the water that the wider public is swimming in, right?
Absolutely that. And it's not that it makes it inevitable that you're going to be pulled back, but it just makes it so much harder not to be. You're starting from such a different kind of baseline, which is really unfair, isn't it, unfortunately? Yeah.
No, of course. And this doesn't just reflect, I guess, these wider inequalities, but it also has, I guess, reverberating effects on the health status of people in prison, how they access health, and how, I guess, how maybe poorly understood some of the other challenges they're facing are, or the nature of stigma and how that relates to then their experience of health and healthcare. And so, Chantal, I wanted to turn to you because you've done some really fascinating research, including kind of qualitative research, and produced some really amazing outputs that I'll link to in the show notes on access to healthcare in this population. I was wondering if you could speak a little bit about how these wider issues reflect and how patients experience seeking healthcare and their health status in prison.
Yeah, no, sure thing. And, as you just heard from Nicola, the people who come into the prison system tend to be from the most deprived areas in our community, and they come into prison with much poorer health than many people in the community. So, for example, much higher levels of physical health conditions, infectious disease, mental health, history potentially of substance misuse, and poorer engagement with community-based healthcare. And just for a bit of information, this is so notable, the impact of all these things put together, that we have a concept of accelerated aging in prison. So we consider people to be 10 years older than their chronological age. So your old age at 50 years old. And we also know that people who are in prison or people who've experienced imprisonment are much more likely to die earlier than someone of the same sex in the community. However, it's not all bad news, because the one thing prison can try and offer is increased access to healthcare. So every single prison has on site a big suite of healthcare facilities. So there is primary care and lots of other complementary services like optometry and substance misuse, mental health, maternity, etc. So that offer is there, and people get a sort of a comprehensive health check on entry to try and identify unmet needs and try and meet those while they're on their prison stay. But of course, the NHS services in prisons do have some challenges, because they are trying to operate their NHS services in buildings they don't own or ultimately manage. And the prison service is really supportive. They want to support health, but it can come down to really small things like certain technologies not being allowed in prison because they pose a security risk. So you can't have maybe Bluetooth monitoring like you could have at home, and other challenges like that. Safe management of medications and things like that. And of course, as well, you could see it as patients having a lack of autonomy or choice in the way they would in the community, where they could, if they wish, choose to register with another GP or choose which hospital they want to go to. That choice and that autonomy to get yourself to appointments is not there in the prison system. And I think one area that really exemplifies this, and a good one to talk to, and coming back to that research, is around hospital care, secondary care. And I could just talk a bit about this. So the way things work in the prison is that when someone needs to go out for a hospital appointment, they need to go and visit the hospital, they have to be escorted by prison officers as part of the security element. And of course, we don't have endless prison officers, and they have other jobs, important jobs that they need to be doing at the prison, which means we can't have endless appointments, unfortunately, going out every day. So that number of appointments is limited, depending on the escorts available. And unfortunately, that means there sometimes has to be an element of prioritisation, so that the healthcare team in the prison, the GP or the healthcare leads, are going to have to make a decision. If I'm limited on appointments today, who has the greatest need to go out? Which is really tough on those healthcare teams. It's not something they have to face when they're in the community referring people to healthcare. And because of this sort of juggling, or if there's an issue in the prison, there can be lots of cancellations because the prison officers have to be diverted. And of course, that is not good for the hospital end either. It's not good for the patient, not for the hospital. Unfortunately, the patient in prison probably won't even have known about their appointment at this point. So because of the security risk posed by taking someone outside, like if they were to try and meet family or friends or not plan anything, then they're not allowed to know that they're going to have a hospital appointment. So you can imagine if you've got something that's really worrying you, a condition that's really worrying you, you have no idea when you're going to go, that's incredible stress on someone. And when they are told, it's often at very short notice for that reason. So people have said in the research that I did, I don't have time to prepare mentally or physically. I might have been at work, just want to take a quick shower. And so there's all that build up in advance. But then when you get to the hospital, you're generally in handcuffs. And the stigma people have reported, and there's often a lot of understanding, people are going to look, I'm in handcuffs, but it's horrible. Sometimes the hospital staff don't know where to put us to wait. Sometimes it's worse being in the waiting room. Sometimes it's worse being funneled off somewhere separate. Often we've had reports that doctors don't necessarily know who to talk to. Should they be talking to the prison officer? Should they be talking, where they should be, of course, talking to the patient? But there's this sort of power imbalance. And often those prison officers sort of have to attend in the actual appointment itself, which again, if you're having an examination or talking about something particularly distressing, it's not nice to have someone there you haven't chosen. And of course, you don't have the option of having family there to support you. So the whole process can be really, really quite stressful. There can also be issues on the handover and return if there's sort of limited information. There's no written discharge summary been sent over yet. Someone comes back late and the prison officers or the patient tries to relay information information on what happened, or medication might have been given that doesn't quite fit with the medication that's already prescribed at the prison, and that needs to be worked through. So there's a lot of ways that could be improved. And one of the things, actually, my PhD research was looking at telemedicine, so video consultations. They have the potential to make huge improvements. People could know when their appointments are. We're not reliant on the prison officer escort to get people out. The healthcare team could talk to the hospital team, hand over that information, no stigma. Prison officers don't need to be there. But the problem is we've got to get the hospitals to want to offer those appointments.
Yeah.
And a lot of the hospitals have moved back more to face-to-face. And so to drop in a video appointment for a prison in the middle of a face-to-face clinic may not work that well, but the benefits it could bring, and also the cost savings. The costs of the prison officer escorts eventually have to be met out of NHS budgets. So the costs and the benefits it would bring if we could move to a lot more virtual work, but we really need the community to be buying into that to move that way forward.
Wow, thank you so much. It's really important to note that one of the aspects of this kind of system is that it starts to offer perhaps some benefits or services, access to treatment that these individuals simply may have not had the ability to access before. But because of the nature of incarceration and because of the nature of these systems, there are these other new challenges to maximizing the benefits of that access. So it's really interesting to hear you talk about ways to overcome them. And just to follow on from that, something that really struck me from watching an animation that you produced as part of your research was the gendered element to that. And I was wondering if you could speak a little bit about that. So we talked briefly about the difference in size and some of the difference in characteristics between male and female inmates in the system. And obviously, when it comes to accessing healthcare in particular, then that poses, I guess, like unique challenges for female inmates in some ways, right? Particularly if you're, first of all, going through all the processes you just described, but you're doing that and you wish to talk about a problem that you may be particularly uncomfortable talking about in front of male officers or that kind of thing. And I was just wondering if you could speak a little bit to that and what your reflections are about the fact that perhaps in some ways it feels like the prison system and perhaps healthcare within that remains almost like masculine by design or designed without reflecting the particular needs and nature of female inmates.
And this is a really sort of timely question, and actually was recognised several years ago that actually, as you say, a lot of the health policies, a lot of the specifications have been built for the prison service as a whole. And of course, like we said, men being far, far, far more overrepresented, that the specifications may be less tailored to women. And that was recognised by the prison service, by NHS. And actually a big programme was launched several years ago called the Women's Prison Health and Social Care Review, which exactly that set itself, big multi-agency working groups across the country, set itself a task to look at the needs specifically of women in relation to a huge broad range of health and social care. I was involved with several elements of that around health inequalities, some work on substance misuse, health needs assessments and other areas. And this culminated, I can't remember off the top of my head now, in the publication year, it might have been 2023, in the publication of recommendations for tailoring health services to women. And there is now a big Women's Justice Board that's been set up to make sure these recommendations are happening and moving through. One of the things, for example, is noting sort of the problems women may experience that have been less recognised in service specifications. So things like menopause or incontinence, and there's going to be a move to set up women's hubs, which are going to help provide that more holistic wraparound care. So I think overall we've got this huge direction of travel and investing in the needs of women and recognising those different needs. And then I think the other part, though, just to mention, and this has been recognised for a very long time, is that many of the women who come into contact with the criminal justice system have had a history of trauma. They've had a very difficult time, and actually that provision of care needs to be really trauma sort of aware and ensuring that it can be offered in a way that people may engage. So again, an example is cervical screening. that can be a really difficult one. A lot of work has gone on for a lot of healthcare teams finding ways to make that more acceptable for women that may not engage in the community. So they've come into prison, but that's a good chance for them to try and get them into a national screening program we know saves lives, and to try and offer it in a way that they may be more likely to access that program. So lots of really good stuff going on, lots of commitment from both, like I said, NHS England and the prison service and wider partners to support this. And so I think a really exciting time to try and improve things vastly for women.
Yeah, no, absolutely. And I'll link to the report that you mentioned in the show notes. And as you say, particularly at this, which is kind of the sharp end of health inequalities and outcomes, it is a place where quite tangible differences can be made through this kind of thoughtful design of services that incorporates some of these upstream factors like trauma experience and that kind of thing. So really fascinating to hear about. And it's really interesting that because these seem like questions around quality of service rather than quantity of service a little bit. And when I think about what we often read about in the media, if we read about prisons at all, it's really often about quantity, in my experience. It's about more prison spaces. Prisons are full. We need to, there need to be more prison spaces, so we need to change the rules around that. And part of that, I guess, focus on quantity versus quality is that we kind of maybe lose sight or don't focus on what the purpose of prisons are in society and what we want them to be, and the extent to which they, as you say, lead to better outcomes for people, like improvements in the trajectory that they kind of went into prison with. So, Nicola, maybe I thought I'd ask you to reflect on this a little bit, just on the kind of way that it's portrayed in the media versus, what your reflections are on the nature and purpose of prisons and where we are versus maybe where we should be.
So it's a really difficult question, isn't it? It's one of those things that's so hard to balance because you've got those really pressing practical problems like there's no space tomorrow. And then there's kind of broader philosophical questions which need to be answered over time but aren't going to be crowded out by not having the headspace to think more broadly because of the urgency. But when we pull back from that, I think it's really difficult because it's a topic where people have got really strong and really divergent views because of their lived experience. And that could be an experience of being in prison, but it could be being a victim of crime as well. And we need to think about that. Or it could be people's wider politics. And so between all of those, I don't think as a society, we've got this strong consensus that we need around the difference and the balance between punishment and rehabilitation. And that makes creating a single goal and a single objective, it's really difficult. All of the research that I've read and everything that I've seen in this topic makes me think that focusing on that rehabilitation purpose rather than the punishment and doing rehabilitation really well, it's better for everybody, not least because we know that in countries where it's been successful, it's been done really well. Reoffending rates are much lower and therefore you have fewer victims of crime in the end. But I recognise it's not the point on the kind of punishment rehabilitation scale that everybody comes to. And we need to be better and braver in making those really difficult political arguments and presenting the data, because the data shows that every time you can support people to break out of those cycles, to truly rehabilitate, get different choices, broaden their life and their horizons, it really does make things better for both kind of the people in touch with the health and justice system and also wider society. We're losing so much talent and capacity because people are being pulled into these like really unfortunate patterns that I talked about earlier, and just those terrible life kind of experiences which takes people out of the talent pool of society. So I think focusing on rehabilitation is really important, but it's a really difficult political conversation.
No, I think you're right. And as a relative novice to this area, and acknowledging that you two sort of have both deep experience of navigating the complexities of this space, right? And just acknowledging those complexities in terms of divergent views. I think something that has struck me, I was a Harkness Fellow in the US from 2019 to 2021 and worked on health inequalities in the US context, particularly during COVID-19. And one of the things that struck me was the parallels in these divergent views, in the sense that there's quite a lot of people who just felt like, well, whoever's in prison right now is who deserves to be in prison, and whatever their situation is, that's kind of that's the justice they deserve, or that's the way things should be. But of course, the US, like who is in prison in the US is so dramatically different from who's in prison in the UK. They've got nearly 2 million prison inmates in the US, like a dramatically higher prison population. They still have de facto debtors' prisons in the US. So you can go to prison for failing to pay a court fine or a speeding ticket in some states. So you have people who are literally in prison because they don't have the money to pay a fine, which, as you can imagine, is like both unjust and sort of exacerbates those inequalities. And there are differences in that even by state. And so there's this strange, almost like cognitive dissonance, where on the one hand, there's this sense that, yep, justice is immutable and whoever is in prison deserves to be in prison. But then there's, like you say, there's the fact that when you look at regional differences or country differences, there are dramatically different trajectories into prison and then out of prison.
Absolutely.
Right? And that should give us pause, but also hope in terms of the way in which we can better configure this.
I think it shows that it's not an inevitable pattern that cannot be changed. There are so many different models that we can use to change what we do and to think about different ways of doing things. And so none of this is fixed, and there are ways to change all of these cycles, but it requires just a bit more bravery and a bit more focus, I think, to get those messages and those arguments across the line.
Yeah, absolutely. I think one of the things that's come up in the podcast a few times is this notion of like radical incrementalism. Like it's the fact that sometimes in these kind of wider philosophical or big sort of politically charged issues, it can lead to people landing on extremes of one side of a debate or other in ways that don't actually translate into action in any kind of way. And I've seen this a lot in my own research on commercial determinants of health, right? Where you maybe find out about some awful lobbying practice in relation to some harmful industry that's affecting UK policy. And some people say, well, that's just the nature of the free market. How dare you criticize that? And other people say, why are you focusing on that? It's all about overthrowing capitalism. Do you know what I mean? And neither of those really deal with the kind of fact that, well, incrementally, maybe we could design better conflict of interest policies and that kind of thing. And I think some of what you are talking about now in relation to prisons and improving health and justice in prisons is about that kind of radical incrementalism. We can design these services to better reflect the needs of women, to better reflect the needs of trauma-experienced individuals, and to sort of incrementally change what the purpose of prisons is and what the outcomes of them are. Would you say that's fair?
I think that's absolutely fair. And that point about incrementalism as well is some of the things that can be changed, that can make improvements. They're not huge things. Like we've learned about some incredible programs, like doing park runs in prisons. Like that's, I mean, it's actually quite difficult to kind of get those things off the ground because there's so much kind of practicality. But in its larger sense, just having sort of physical exercise and a community and something that feels so normal, it can make such a huge difference. So some things don't have to be huge, kind of rip the system down things. It's just small changes that make things better over time, like you say. And this is going to be a long journey. We're talking about long processes, but definitely you can make positive steps and positive first steps.
Fantastic. I think so. Chantal, before we get into one of those positive steps, I hope, which is your current work in relation to the CMO's independent report, I just wanted to give you a chance to maybe reflect on that also. Does that chime with your experience of working in justice and health over this time? And do you have any reflections on that tension perhaps between, I guess, the sort of the often simple narratives of what needs to be done versus the reality of how hard it is to get things changed?
Yeah, I can reflect on that. So I guess I work in the health and justice circle is quite small. I work closely with people, like I said, from across a lot of different organisations. And one thing in common is they're really passionate. They are really, really passionate people about trying to improve health and the contribution that can make towards sort of rehabilitation. Because, of course, it's only one element. people have other needs when they're trying to rehabilitate back into the community, but having good health is going to support a lot of those needs to be met. So I would say the partners work really well. We work to what are called national partnership agreements. So they're formal agreements which are signed by the chief execs of all the agencies that have a role in improving health, and they commit all the partners who sign up to them to delivering certain actions over, it's normally around a 5-year period, they've been extended recently, to improve the health of these populations. So I'd say on the inside, working with the partners involved, it's an incredibly positive movement and positive, intent to make change. I guess, yes, that sometimes where we can see polarized is in the media, for example. We often see stories about the capacity crisis, or reporting, for example, that they recently released the sentencing review, and the media focused on some aspects more than others, and you would have to make a judgment as to whether they focused on the more positive or the sort of more tricky areas to discuss. So I think that's hard, but there is always going to be that public debate around these issues. But like I say, for the people working sort of hard in the system, there is generally really positive, good working relationships, and a drive to make things better, and acknowledging, like you say, it takes time and it takes investment.
No, an excellent point. And I guess on those topics of time and investment, one of the potentially big advances in this kind of wider area has been the UK CMO's independent report on the health of people in prisons and probation. And you've been involved in this work. So I was just wondering if you could tell us a little bit more about it, to the extent that you're able to, bearing in mind that it's not quite in the public domain yet.
Yeah, and I'm not allowed to give all the spoilers. You'll get the full headlines in the summer from what I understand. But yeah, it's been a while now. We've been working with CMO. He has shown a real interest in the criminal justice space over the last few years. I was lucky enough to go on a visit with him and others to a prison and to a high secure forensic hospital, and really saw his passion for the area and speaking to the people working and living in these settings and wanting to understand the challenges they faced. And I imagine that sort of was instrumental in a decision we heard last year, is that he was going to lead, as you said, an independent report into the health of people in prison and probation in England. And as such, a big multi-agency group was brought together. Like I said, we all tend to be involved. It's a small field. And the plans were drawn up to write this very comprehensive report covering a lot of different areas to do with health. So it's got a lot of broad chapters, things like wider determinants, complex care, older people, etc. But the bit I can talk a bit more closely to is health protection. So UKHSA were asked to lead on the health protection chapter. And I would say, as quite a sort of a niche area, like I said, covering infectious diseases, antimicrobial resistance, pandemic threats, environmental threats, probably isn't something, and often rightfully so, that's spotlighted in the much broader reports that you may see on health and justice, because it's only a small part and much smaller in comparison to things like mental health or substance misuse. So it was a really good opportunity for us to spotlight issues and inequalities in this health protection space. And what was great is that it really united the teams across UKHSA. So teams that focus on specific areas like tuberculosis or STIs or climate were all really engaged and really wanted to see how they could interrogate their data to try and find prison populations and highlight these inequities. And actually the organisation as a whole now has a whole thread that runs through it, a whole health equity strategy, given those inequities we saw in the pandemic. We saw certain people were much worse affected by COVID, and we want to make sure we build on that moving forward, and we pay due attention to groups who may be more likely to suffer disproportionate outcomes for health protection issues. So we worked with those teams. We had novel methods to try and interrogate the data. Again, a big step forward, trying to identify test results or samples or people who were in prison. And we do that through postcode, actually. Postcodes for prisons are quite unique. They don't overlap with other areas. So we're not finding people. We don't have people's names or numbers, but we can say, well, this is linked to a certain address. So we know that this sort of infection or outcome is recorded in a prison setting. And there's still quite a lot of challenges to that, though. It's hard to accurately know your population denominators, accurately know how many people of which age went through the prison population. Lots of complicated reasons I won't go into why that's difficult even for the prison service to measure. And also we get a bit of a blind spot for probation because we can't use that address method to try and find people on probation, because people are scattered far and wide across the community. But what we have ended up with is a really data-rich chapter. I'm really proud of all the data we've got in there, novel analyses, and I think we might maybe touch on the findings in a bit, but the sort of stark disproportionate differences it's highlighting. And again, that continued need for action, investment, changes, and working with people with the experience of the criminal justice system to understand their experiences and build on the services moving forward.
Wow, really fascinating. I mean, I have so many questions about this, but I'm conscious that some of the answers may be kind of behind a veil until later this summer. I mean, I wonder if you're able to provide an example or an instance of the ways in which we maybe failed to understand the unique ways in which infectious disease is maybe either ignored or the effects of it exacerbated or its spread exacerbated in ways that just we simply don't understand unless we adopt the novel approaches that you're talking about, and unless we involve people who have direct experience of these services.
Yeah, so much I can say on this area, I guess. So let's put this first into the first context to why it's a high-risk environment. So like I said, you've got people who are in much poorer health, less likely to have engaged with healthcare coming into prison in the first place.
Yeah.
And they're people that may have had other social risk factors, so may have been homeless, may have been involved in drug use or other areas that have increased their risk of contracting disease in the community. So a proportion of people in poorer health likely to suffer poorer outcomes, possibly more likely to have had some element of disease transmission, and less likely to have been diagnosed. So that's the group of people. But then you've got the setting. And the setting itself is one that, again, is really quite high risk for spread of disease. And that's because it's closed and it's crowded and it's high contact. There's lots of people coming in and out. There's staff coming in and out. There is a lot of opportunity for disease to spread quite rapidly, especially respiratory disease. And that's why we saw a lot of prisons in outbreak, some almost continually through the pandemic, because they just had people coming still in and out of the justice system. It was near impossible to keep COVID out. Very well managed and all the best will in the world, but it is just a very high risk environment for disease transmission. So we talk about that in the report, and then we spotlight particular areas. And one that I would speak to here, which I think is the one that's sort of really at the top of my list at the moment, is around tuberculosis. And tuberculosis is a spotlighted issue for the country as a whole. Tuberculosis levels are going up of what is traditionally thought of as a Victorian disease, often framed so in the media. And we are seeing quite a lot of tuberculosis in our prison system, and a lot of people not necessarily catching it in the prison, but coming in with it. And like I said, a lot of those risk factors, such as homelessness, may be associated with that. And the problem is that with TB, it can be really easy to miss the symptoms or to discount them as something else. So you've got a cough, but you are a very long-term smoker, or you may have night sweats or be losing weight. But if you've come into prison and are transitioning, perhaps off of drugs that have been used in the community, you may get some of those symptoms because of that, rather than the people initially thinking TB. So there's challenges with making sure we spot it at a really early opportunity. There's challenges with people both working in prison having that much awareness of TB. Like I said, there's so many other things they're trying to support people with. So mental health and other issues. TB is a drop in the ocean. So we're trying to raise a lot of awareness. We've done a lot of webinars. We're doing communications on prison radio for people that are resident in prisons to sort of say, if you've got a cough or something, seek help. If it's been going on longer than 3 weeks, if you're losing weight, seek help. Think TB is one option. And the same thing to staff. And I think there's things we could do around improving that. And of course, if we do get a case of TB, it is a respiratory pathogen. And if someone is infectious, it can mean that by the time we identify that they've got TB, we've got a lot of work to try and find and screen both staff and resident contacts around them to try and make sure we identify any further transmission. Even more complicated if people have left prison and we've got to try and find them somewhere else. And that could be, again, coming back to the fact this is around money and power. It can be hugely costly hugely costly exercise. Whereas if we could get more investment and trying better ways to try and find people at an earlier stage, better technologies, we may reduce that sort of downward burden both on people's health, poor outcomes, but the cost of trying to manage that disease. So TB is one that's definitely drawn out as a strong theme in the chapter, and a strong theme I think it will be for us as a team moving forward. Then there's other areas we talk about. So the longer term elimination goals that our country is signed up to deliver, international goals, of which prisons are an important part of that. So things like bloodborne virus elimination, TB elimination is another one of those. Big focus on hepatitis in prisons, big focus on hepatitis C over the last few years. We want to start thinking more about hepatitis B as well now, for example. And then also we talk about environmental threats. Again, it's an area, there's not much research, there's not much data. We're scratching the surface and starting to see that hot and cold weather can really extremely affect prisons. Again, unsurprising. We've got some new build prisons, we've got some very old prisons. You can't open a window necessarily in a prison. You can't just go and get yourself a fan if you want one.
Yeah.
You are reliant on the support of that environment to manage those temperatures. So it's a lot more work for us to do around there. And then we also talk about that as we mentioned earlier, the disproportionate burden we see in some areas for women versus men, which again may be easy to miss when you look at the numbers, and the numbers seem small in absolute terms because there's not that many women. But when you compare the rates, when you can calculate those denominators, difference is quite stark. And the one, again, which I think will be drawn out very clearly in that report is around sexually transmitted infections and the impact that they are having on women in prison. And again, we have plans in place and working with our NHS colleagues to think what we're going to do and how we're going to act on those findings, and a lot of commitment from across our partners to take action on them. So, I think it's going to be a really good opportunity to spotlight these goals. And what I think is really good about a CMO report is it reaches audiences that aren't necessarily already engaged in the topic.
Yeah.
So we don't want to preach to the people who already know there are inequalities in the system. We want to reach the people that maybe don't always think about it. So maybe, people working in local authority public health, people in our integrated care boards. I could introduce telemedicine, that will make a difference. Or what about my continuity of care for when people are leaving prison? Or how does that prison vaccine coverage affect the risk of measles spreading in my area? What if measles got in the prison and circulated rapidly and came out? Is there a risk? Is there low MMR coverage? So I'm hoping that this will really draw people in that aren't necessarily thinking all the time about this area and prompt them to start thinking about it and start working on initiatives to try and improve the health, which ultimately is good for the wider community and brings dividends to all.
Wow. Then no, thank you so much. Frankly, I think you've given a lot more information about the chapter than I was expecting in a positive way. I was worried that it would all be sort of super embargoed, but even just those reflections are incredibly, incredibly important and useful in thinking about the challenges in dealing with infectious diseases in these contexts, the stakes, what's at stake for the individuals involved, but the wider community, and what the promise is of actually delivering a report like this and seeing it reverberate beyond the usual audiences. So really, really excellent stuff. And it seems to me, the more that we're talking about it, is that there's a real link between the wider inequalities we described and how those link into prison, the rehabilitative role of prisons in general, and providing a kind of an improvement in health status as part of that offering. Something that we've talked about in previous podcast episodes is the notion of health as being a lot more than just an indicator that, we want that the CMO maybe cares about in terms of improving, that ministers maybe care about in terms of sort of demonstrating success in reducing waiting times or in reducing infection rates. But health is kind of a means to an end. Health is a means to any end. If you are in good health, that opens up a lot of different opportunities for you that if you're not in good health, you just don't have those to the same degree, right? In terms of, just choosing what to do with your time, autonomy, agency, being able to pursue various activities with various individuals. Health is a means to any end in some ways. And so providing that means should be a kind of key function or a key priority of rehabilitation. So this just my reflection on what you've just described, which is really, again, really, really helpful. So I'm conscious of time, and you guys have been incredibly helpful in sharing these insights with me. I just wanted to maybe circle back to our original point about the links between kind of wider social inequality and who ends up in these kind of services and situations, and thinking about what you feel lies upstream when it comes to health and justice, right? So we've talked about dealing with treatment in the prison service, improving quality. So what do you think, so beyond rehabilitation, which again is sort of like treatment, right, in the context of health, and moving to prevention and thinking upstream, what are your reflections for priorities or reflections, especially for people who are maybe not so familiar with this area, on improving health and justice over the long term? What can be done upstream, out with of the health system and out with the justice system? Maybe I'll throw it over first to Nicola.
Thank you. It's such an interesting question. I think when we leave the health sort of sector and we go out to that broader kind of societal question, I think a lot of the things that I want to say we've already touched on. So it's more a case of drawing them together. I think that need to have a really calm, evidence-based philosophical discussion about what we want to achieve from our investment in health and justice and where we want to take that in future is a societal-wide conversation that draws in everybody's different experiences. And we need to look really calmly and dispassionately around the evidence around what works, particularly with regard to breaking those cycles. And that will be things like greater opportunities in early years, in schools, in safe housing, in good jobs, all of those things that we all want. It's kind of improving those things helps not just kind of people in touch with the criminal justice system, but everybody, making sure that we're not systematically disadvantaging people by the policies that we're kind of putting out there. Because we know there's some fantastic models internationally. So looking at those as well and taking those good lessons, using that evidence, and recognising that the current kind of status quo of high levels of reoffending, which we are seeing, it's terrible for everyone. It's terrible for all of society. And the tone of the debate and the discussion, it's led from the top and it's led from broader society. And so only kind of those kind of broader conversation leaders, they have their power to really change the tone, and that's really important. One thing I learned when I was working on the report, because I'm someone with much less experience than Chantal, is just how much fantastic examples of work that's going on there are out there. So as Chantal said, it's a sector that's led by really passionate people, and there's so much good just stuff, and being able to learn and share those best practice examples across the sector, it's vital to ensure that they spread and they become normal, because prison staff and charities and lived experience advocates, they're all working so hard to try and make things better, and there's so much that we can just take from those. So coming up with a better way to share what's going on in individual prisons and making sure it can spread across is so vital. Chantal mentioned earlier STIs in the female estate. There's some fantastic examples of work going on in individual female prisons to support women and to get people tested, and it's making sure that they spread. The other thing I didn't realise really before I started doing more work in this area because of my lack of experience is I didn't realise the role of prisons as a place to access services for people who are really disengaged within the community. So I think a broader recognition that when you have people in the prison, when you've got residents, it's a real opportunity to get things in place that aren't in place outside, because it's so hard for people with really difficult, really chaotic lives to access those services, not just health, like education, housing, qualifications, all of those things. I think seeing prison as a place to access and to get things in place and to support people rather than that kind of place of punishment, getting that broader conversation change is absolutely vital. And then the final thing I would say as well is we need to do more to listen to the lived experiences of people who have that lived experience of being in the criminal justice system. some of the best programs that I heard about when I was sort of involved in the report, they were peer support programs. There's some absolutely incredible advocates out there who have lived experience, but because of the inequalities that we've talked about, the characteristics of the population, it can be so difficult for people to do that. And we need to work hard to support people to get involved in that, despite all of the other things they've got going on, because it's the people with lived experience who will have those really different ideas and those really innovative solutions to how to make change. So thinking of the people who are residents in prison as also kind of a catalyst for ideas and for making a positive change, that kind of change of mindset is really vital as well. So lots of things, I think, can be drawn together.
Thank you so much, Nicola. Really fascinating. And I have to say that the route that I had into this was exactly that. It was hearing one of the lived experience voices from the piece of research that Chantal did around experiencing healthcare in prison. It was that lived experience voice that really shook me and got me thinking about the challenges that this particular population face, and asking questions like, you know, well, what does success look like? What do we really want out of this? And what can we do to improve it? So I completely echo that. And I just wanted to give the final word to Nicola. I appreciate we're nearly out of time, but really grateful for all the contributions you both have made to this space. What are your reflections, Nicola, on the upstream and sort of the, you know, we've talked about health in all policies, right, as being something that we want in the context of public health. Well, what does justice look like in all, you know, justice and health in all policies look like? And what are your reflections for how we might better get there?
Oh, that's an interesting one. I wonder if Chantal might be better for that. That's a good.
Oh yeah, sorry. I accidentally said Nicola, and I meant to say Chantal, but that's fine. I'll delete this little bit.
I was going to come in on a slight angle about the sentencing review, so I don't know if we can I was going to just come off the back of Nicola's, but
yeah, should I? Would you like me to rephrase that question?
And I can add on the health and all policies as part of that. But if I could just come in off the back of what kind of the reflections of what Nicola said.
Yeah, definitely.
I think.
Deleted. Yeah,
okay.
That's fine.
Okay. Let me just make my note on my bullets. Health and all policies. All policies. Okay.
Did that make sense? Though what I mean, like the idea of like.
Yeah, being everyone's business.
Yes.
I think is.
Yeah, exactly, and it being sort of a policy goal, you know, in each of these areas, like education, housing, whatever, like that.
I'll put this for a minute. Cross-gov. Okay. So shall I just start? You could.
Yeah, go for it. Okay. You cook.
Well, first of all, I have to say, Nicola, you are underplaying your knowledge and experience in this area, and you mustn't do that. So, during it, I think Nicola really covered very well the upstream determinants, but I'll just touch a bit on actually just wider determinants and maybe less around the prevention side. And I think it's about, for people that are coming into contact with the criminal justice system, it's that move towards less people going into an actual prison. And that's something, like I said, the sentencing review was recently released, and that is a real core focus. Unless people really, really, really need to be going into prison, trying to find other ways for courts to deliver sentences, community sentences, fines, etc., other types of punishment, as they would frame it, for crime. Because we know that going into prison, it impacts people's families, it impacts people's home life. It can interrupt work, disrupt support networks, overall, a huge amount of disruption. We really, have to think very seriously about the benefits of sending someone to prison for a short time with all that disruption. And that's exactly what the sentencing review has framed. So there's something about moving in that direction. But of course, in moving that direction, we've got to make sure we don't lose those benefits we've talked about. So the benefits of having that increased access to healthcare when you go into prison. I don't think we've bottomed that out yet. That's a big task for us all now to think about. That's a big task for systems to be thinking about. If you've got people who would normally, very vulnerable people who would have accessed that in prison, how are we going to increase the chances that they will access in the community? How can integrated care boards serve their probation population and spotlight them as a priority group? That's something we need to work through. We also need to think about the people that are still going into prison, how we really support them when we leave. So coming back to those wider determinants, people need stable work. They need a home. They want to connect to family. we know people are more likely to reoffend if they don't have these things. And we know health is probably going to be secondary to those elements. We need to get those core basics right before someone's going to start thinking about their health and what they need to do to improve it. So we've got a lot to think about how the way the justice system may change, I think, albeit in a positive way, but how we increase those health benefits. And of course, in England, we have a policy for prison or for healthcare for health and justice populations of equivalence, which is that they are entitled to the equivalent care. But whether you talk about entitled to the equivalent care or equivalent outcomes, and if we're talking equivalent outcomes, we have to accept that some populations will need more access to care to reach those equivalent outcomes, which I think is where we all sit in terms of where we're thinking about equivalence. So I think moving forward, like I say, as the landscape changes, as more people are serving terms in the community, as we come to recognise more the impacts of other areas of the system, of education, of housing, of work, we need this topic to be embedded and thought about and discussed, across all areas of government, across all policies, across all areas of the health and social care system, and recognising this is a real, as we term it, a core population, a core 20+5 population group that really can experience health inequalities, whether they're in prison or remaining in the community. And we need to make sure that the system is all aligned and trying to tackle these sort of root causes, increase prevention, but also make sure that they're really providing the services people need if they do end up in prison or in touch with the probation service.
Fantastic. I think we've covered it all from the sort of primary prevention all the way through to treatment quality. And just, I think, huge thanks to both of you. I think your responses reflect both your passion in this area and the breadth of expertise that you've sort of applied in trying to make positive change. So huge thanks for all that you're doing for health and well-being, and good luck with the launch of the report later this summer. It's been wonderful to speak to you both.
Thank you. Thank you for the opportunity.
Thanks so much for having us. Always a delight to raise the profile of health and justice.
Well, that's it for another episode of Money Power Health with me, Nicola Dennis. I hope you enjoyed the conversation. Huge thanks to my guests, Chantal and Nicola, for their dedication to this topic, for all the work that they have done and are continuing to do. And I really hope you'll join me in delving into their findings when they come out as part of the wider CMO review, and in thinking more deeply about the ways in which the wider forces that shape health interact so acutely with people who are experiencing the justice system. And incredibly, again, as I mentioned at the outset, important yet often underappreciated topic that my guests today are doing a lot to help surface, with the help of many who are experiencing these issues directly, the voices of lived experience. I hope you'll continue to join me in future episodes of Money Power Health. I'll see you in the next episode, and we'll leave Charlie to read us out. Take care.
If you enjoyed this podcast, please consider leaving a rating. It helps other people find it. The music in this podcast was by Daniel Manny. You can find more information about his music in the show notes. This announcement was read by the very talented Charlie Manny.